And now I request Dr. Pradeep Sharma ji. He also requires no introduction. At least all of us know him very well. So he would be speaking on reinforced plications.
Thank you, Professor Yogesh. I think we are having these plications, revisiting ourselves because of some changes which have happened, and that is how we are going to talk about the newer applications of that. So as you know, for strengthening procedures, generally we have had resection, but now we are more and more shifting towards plication. I have no financial interest in promoting plications. It has been that for since I think 5 or 6 years that we have been trying to find more interest in plications, and why I will tell you what's the reason. So you'll see here that resection is the conventional strengthening procedure, but the disadvantage, as you would know, is that it's not easily reversible, that compromises the blood supply, and also there is a risk of losing the muscle or slipping at least. Plication has that advantage that it strengthens, it's vessel sparing, shorter operating time, causes less surgical trauma, inflammation and hemorrhage, and also it's reversible in the early post-op period, and of course there is no risk of losing the muscle. Let's have a small video of this reinforced plication as I do. And in this, what we do here is that medial rectus has been hooked from the fornix approach, and on either side the intermuscular septum are incised up to 8 to 10 mm, and the check ligaments are separated. And just like what you do for resection here, we are marking the same nomograms I am using for resection as we were doing earlier. And the 6-0 vicryl sutures are being used here. And so first is you imbricate the muscle. Then next step is to imbricate the sclera. So from muscle, the sclera, and then back to the muscle is what we call the reinforced plication. So this is one bite in the sclera and then back into the muscle. This is a figure of 8. Now this helps us in folding the muscle very easily. So once you have done that and you place an iris depositor in between and you just tighten the sutures, the muscle neatly folds, and this is what we want, that the fold is buried underneath and the sutures can be tightened. At this stage you do an FDT to see if that you have not over tightened the globe, and if it is to your satisfaction you can close the conjunctiva. So this is as simple as it could be, and the steps, as you may have seen, are these that we have to talk about. So if we had done a study to compare the effects of resection versus plication, and we see that similar cases if we have, there will be redness of course in the first week period. The lump is more in the plication in the first week, but after a month the lump disappears almost. In few cases it may be there for about 6 weeks or 2 months, but usually it will disappear. And I sometimes find that the plication eye is much cleaner than what we will have post resection. The main advantage one is that it's early reversibility is possible. In resection you would have to totally undo it. Even if you went wrong, let's say you will have to do a recession of a resected muscle, you have to pass sutures and all. But in intermittent divergent squint, sometimes we come across cases when we have overdone, and in that case you can easily reverse the sutures in the first 2 or 3 days, and you will be able to undo the overcorrection that you have done. This we have done at least in 2 or 3 cases earlier when we had a case of overcorrection of an IDS. But now we have another thing which has come over to my mind, and that is 1.5 surgery. So now what I call 1.5 surgery is in exotropias of about 35 prism diopters. So this is an in-between situation. If you remember, there was an ad some time back of Amul chocolates that I am too old for this and too young for this, but you are just right for Amul chocolates. So that is what I say, that 30 prism, up to 30, 25, 30 prisms, 1 muscle is sufficient. 40 prisms, 2 muscle, no doubt. But what happens if you are 35 prisms? You are in doubt. And that's where I was doing this, sometimes undoing the plication halfway. So now I have started doing for this 35 prism diopter bracket, LR recession, same amount, 7 mm, but the MR is a central mini plication. It's a half the effect, and that is 4.5 millimeter bite. So this is what you'll see here. Sorry. So it's similar. What you'll see here is in this, this is a fornix incision again, the medial rectus hooked, and neatly you get the intermuscular septum on either side, check ligament separated. And now here there's just one single bite you take, sparing the vessels, of course. In both these the procedures, we try to see that the vessels are spared, and then we are taking this muscle, sclera, and then muscle bite, and then you pass the iris repositor and fold the muscle. So there is a single suture. Even to undo it's much easier now, but mostly you don't have to undo if it is a 35% diopters, and this is where I have started doing this more and more, 1.5 procedure. Yeah. Yeah. So this is the Green's hook, and then the small hook passed and check ligaments are separated. So this central bite is taken. Now this iris repositor is placed in between, and you tighten this suture. Both these ends are pulled, then the muscle folds on itself, and you can then close this suture. And once you have ensured that it is the right tightening, you will switch that. If you have to do a vertical shifting, will it be a problem with plication? One would think that resection is easier to do a vertical shifting, but usually what we do is half muscle width shifting for resection, and the same can be done with plication also. And as you can see here, so basically what we will do is pass the sutures and then pass them in the sclera diagonally placed. So this is the, let's say the one end. So inferior end we have passed in the muscle, then the superior end of the insertion we have passed in the sclera, and then back into the muscle. So this is a diagonal thing which is there, and the upper muscle suture will come 5 millimeters above on the sclera and then back into the muscle. So once we are going to fold, it will cause a diagonal shift of the muscle, and that serves well for our A or V patterns. When you have DVDs, we were talking about DVDs just now, and I would say if you have a inferior oblique overaction, of course you do an IO80, but if you do not have an inferior oblique overaction, what do you do? Then in that case, earlier we were doing superior rectus recessions or with Farden. I would now suggest doing an IR plication. So this is with an inferior oblique overaction, but this is without, and here we are doing a IR plication. Surgery I may not have the time to show, 30 seconds, but it's similar what you do for the medial rectus. So mini plication, which has been talked about by Kenneth Wright, I have tried to make it like a reinforced mini plication, and it works very well, especially for these small angle deviations of 8 to 10 prisms. And sometimes you have this hypertropia or the cases of Hyman-Belchowski's phenomenon, these children who have a small angle deviation happening or small DVDs, then we can do this procedure. So to conclude, plication can be effectively used as an alternative to resection in routine horizontal rectus muscle surgery, especially the medial rectus. As a mini plication also it can be used, and it corrects small deviations. So now I have been talking about plications all over, and it's received very good reception. I would like to say that we should be switching over plication at least for the medial rectus and for the inferior rectus whenever it's required. Thank you for your patient listening.
Thank you, Professor Pradeep, for very interesting talk. I think these are interesting techniques, and we need to adopt them. I think for small angle deviations, they are really good.